get some reaction from someone who knows the challenges facing our healthcare system right now quite well. We're joined once again by Dr. Alika Lafontaine. He's the president of the Canadian Medical Association. Dr. Lafontaine, thank you for making the time again.
Thanks for having me.
Now, you and I spoke before the proposal was made public. This is our first time to meet face-to-face and talk about it now that it's out there. And again, the money is not what the provinces wanted, but immediately there is this $2 billion top-up to the Canada Health Transfer with no strings attached. How do you see that helping the crisis in healthcare that's being felt right across the country right now?
The unrestricted part of the health transfer is really important. So provinces can put additional money into things that are quite urgent. So what do we know? We know that health providers are really struggling to maintain the way that they practice within the system as it's currently designed. I do believe some of that money should likely go to salaried employees like nurses to make sure that we properly incentivize people to stay in the workforce. I think having that money be put into types of team-based care that have been shown to be effective in the past. In Ontario, there's family healthcare teams. In Alberta, there's primary care networks. These are places that money could easily flow. And then there are transformational initiatives happening throughout the country. One example is PEI with their use of the medical home model of team-based care. All of these types of approaches do need funding, and I think this unrestricted part of the health transfers is one way to do that.
Okay, so that's the unrestricted portion of what's being offered. There's also the tens of billions of dollars that would come with conditions, and part of that are these side deals that Ottawa will negotiate with the provinces. But to access that money, the provinces have to also chip in on what's called shared priorities with the feds. We're talking about things like home care, long-term care, community care. Will those stipulations address the crisis that we're in right now as well?
So there are two different types of transfers outside of the unrestricted envelope. There's the Canada Health Transfer, which has the requirement to invest in those areas that you mentioned before, but then also invest in data. And then there's the bilateral agreements, which will be, more province and territory specific type agreements that also include a stipulation that there needs to be some movement forward in helping workers be more mobile between jurisdictions, something that the Canadian Medical Association has definitely called on provinces and territories across the country to enable. And so I do think that these are actually the right priorities. If you look at what the advocacy has been around as far as changes in the healthcare system, these shared priorities are exactly what we've been calling for. And I think when you sit down and talk to the provinces and territories, there's been a convergence of priorities. And you don't often see this in health transfer negotiations. And I think this is a really creative way of having people focus on fixing the same problem.
Mm-hmm. Now, there is this concern. We've heard it from a number of different parties, the NDP among them, that this proposal doesn't do enough to protect the public nature of healthcare delivery. What's your thought on that?
I think the biggest threat to public healthcare delivery is a poorly functioning public healthcare system. We've seen in previous polls, one as recent as this week, that there's a larger than ever proportion of Canadians that actually think private options are something that should be explored. The reason for that is because people are not having good experiences with access. People are not having good experiences working within the healthcare system, and so are cutting back hours or choosing to work elsewhere. If these investments focus on these shared priorities, I think we really do have an opportunity to nudge the system in a direction that can change the experience of patients. And if we fix that, then I think we actually do fix the issue that we have with the call for private healthcare. The best solution is actually fixing the public healthcare system.
Okay, but the fact that the money is not what the provinces were looking for, does that not almost necessarily create more opportunities or perhaps a turn to more private care within the system?
The answer to that is maybe. One of the biggest challenges that we've had with any type of care transfer that's happened in the past historically is that if you give too much, a lot of jurisdictions just end up doing the same thing. And so one of the big fears is overfunding the transfer, so provinces and territories don't have to choose new directions. The other side of that is underfunding the transfer, so it doesn't provide that adequate nudge, those resources that you need to actually transform the system. So there's that sweet spot between too much and too little. I think the answer of whether or not we've given enough to provide that nudge, we'll have to see as provinces and territories move towards signing these agreements and working towards bilaterals. But, I'm pretty hopeful that we might be close, if not in that zone. That might be the nudge that we need to actually change the way that healthcare is provided in the country.
Okay, actually, let me build on that then. And correct me if I'm wrong here. Essentially what you're saying, and that there might be a silver lining to the very fact that Ottawa did not give the provinces everything that they are asking for, because that will, create the need for innovation?
Well, this is what ends up happening in healthcare. We're very used to doing things the same way that we always have. Crisis is really the precursor to innovation within the healthcare system. We are in the worst crisis that we've ever been in the history of the healthcare system. And so people are exploring things that they never would have explored before. One example is, pan-Canadian licensure. We were very satisfied with the way that we isolated providers across different provinces and territories. With COVID and the other problems that we're having right now with health human resources, we're now being pushed towards exploring these new ways of doing things. There is a danger with giving too much money to the system that all it needs to do is just spend that money to maintain the status quo, that things won't change. And so, the real question here is whether or not we are in that sweet spot, whether we're in that zone where we've given enough money to provinces through health transfers to enable change. And I don't think we'll know that until we give a bit of time for this to work its way through.
Yeah, I'm wondering how much time, though, because as you and I discussed earlier, we are in a country right now where millions of people do not have access to primary care and have no faith that they'll actually get the care they need in emergency care if they need it.
So, one of the great things about how the Canada health transfer portion of this health transfer agreement is written is that data is an important part. So even when we've invested large amounts of money in the healthcare system, we've had very poor ways of identifying whether or not that funding led to any change. So one of the great things for Canadians to have faith in this transfer is that there actually will be data sharing. There will be some sort of evaluatory framework to see whether or not things are being pushed along. Now, if in 6 months from now, a year from now, provinces and territories are really trying their best to make these changes, and we're finding that despite these changes, there's additional monies that need to be invested, I think at that time, Canadian Medical Association, patients and providers across the country need to call for additional investment. But right now, since we don't even measure those things, I'm hopeful that this is a starting point to actually change the trajectory of how things have worked in the past.
Dr. Alika Lafontaine, really appreciate the time. Thank you.
Thanks for having me.